Hello, everybody, and welcome. My name is Dr. Adam Rubin, and with me is Juliana Codino. We make up the voice team at the Lakeshore Professional Voice Center, which is part of Lakeshore Ear, Nose, and Throat Center in St. Clair Shores, Michigan. And we are thrilled to be part of the NSDA's virtual symposium. Obviously, we would love to be doing this in person, but during this time of lockdown, we are confined to the comfort of our own homes. I hope you all are staying safe. Because we are in our homes, please excuse any dog barks or children screaming. We hopefully won't get too many of those, but you never know. So we have been given the tall order of discussing vocal fold paralysis and paresis. At the Lakeshore Professional Voice Center, we treat all voice disorders. Obviously, we take great pride and pleasure in treating people with spasmodic dysphonia and tremor. We also take care of benign vocal fold lesions, vocal fold paralysis and paresis, precancerous and early cancers of the vocal folds, as well as swallowing and airway issues. And of course, we love taking care of the professional voice, as you will see in this beautiful larynx of a young performer.
Think of me fondly.
This is a view of the larynx singing with a flexible laryngoscope passed through the nose so we can visualize the larynx on a monitor. So if we are going to talk about vocal fold paralysis and paresis, we need to talk a bit about some physiology of the larynx or the voice box and the vocal folds, which it contains. If you see this picture on the left, the vocal folds need to close in order to make sound. They close so air pressure can build up beneath them and cause them to vibrate. And that vibratory cycle is what will give us pitch and tone. As you can see here in this little GIF, the vocal folds vibrate by closing from the lower lip to the upper lip. And then that vibration is propagated through mechanisms I won't get into at this time. But of course, the vocal folds are really just the strings of our instrument. If you were to hold a violin string taut and, well, first of all, if you don't do anything to it, you won't hear any sound. But if you were to strum a bow across it, you'd hear pretty much just a buzz because you're hearing a very narrow range of frequencies. So like the violin string, our vocal folds need a bow or power source to cause them to vibrate. And as I mentioned, that's our breath. And then we also need a body of our instrument to resonate the sound and bring out all those rich harmonics. Hopefully we all have a Stradivarius, but that's not always the case. The body of our instrument is everything above the vocal folds, the part of the larynx that's above the vocal folds, called the supraglottis, the throat, the mouth, the nose, etc. Now, I mentioned that the vocal folds have to close in order to produce voice. Well, that's true, but they also have to close for a couple other even more important reasons. One is they close to protect the airway from food or liquid or other things we don't want to go into our lungs from going into our lungs. They also close so we can produce a cough and bear down or valsalva. But believe it or not, the most important thing that the vocal folds do is to open. And they open so we can breathe. They provide an airway, a passage of air into the lungs. They also stretch. When the vocal folds stretch and provide various amounts of tension, they're going to provide the capability of producing different pitches. The tighter they stretch, the higher the pitch of the voice. So when everything is nice and normal and healthy, we hear a clear voice.
When the sunlight strikes the raindrops in the air, they act like a prism and form a rainbow.
And then when we look at those vocal folds, we see healthy vocal folds that can vibrate well and open and close and stretch. And you can see as the vocal folds stretch tighter and become longer, the pitch becomes higher. When one refers to a paralysis, they're talking about a problem with a nerve that's not functioning, so that the muscle that nerve is sending a signal to doesn't move. It can't move. If the nerve is only partially injured, we call it a paresis, in which case the muscle it sends a signal to might move, but not normally. It's hypomobile, as we call it. But a vocal fold can also be immobile or hypomobile due to a structural injury. The vocal fold rotates on a complex joint called the cricoarytenoid joint. Its motion is quite more complicated than typical joints. Not only does it move side to side, but it also tilts and rotates. And to make this all the more complicated, there are numerous muscles within the voice box, within the larynx, that all work synchronously in order to not only open and close the vocal folds, but to change the amount of tension on the vocal folds. Now, the majority of these muscles do affect closing of the vocal folds. This muscle in the back, called the posterior cricoarytenoid muscle, is actually the most important muscle in the body because it is the muscle that opens the vocal folds and allows us to breathe. There's another muscle here called the cricothyroid muscle, and that muscle is very important because it actually alters the angle of the cartilages of the larynx so that the vocal fold can get different amounts of tension. In other words, we need that muscle to stretch our vocal folds and have an upper range to our voice, increase the pitch. So nerves all come from the central nervous system. Here you can see a diagram of the brain. Down here is the brain stem. There are two nerves that provide signals to the muscles of the larynx. One is called the superior laryngeal nerve, and one is called the recurrent laryngeal nerve. These both come from a nerve called the vagus nerve, whose cell bodies or centers are within the brain stem. The recurrent laryngeal nerve innervates the majority of the muscles in the voice box, except for one, which I will come back to. It's called recurrent because it travels all the way from the brain down into the chest, and then it loops back around and enters the larynx. The superior laryngeal nerve is this smaller one, which comes off that vagus nerve, as I mentioned. This innervates the cricothyroid muscle. The recurrent laryngeal nerve provides a signal to all the other muscles of the voice box, except for the cricothyroid muscle. Again, the cricothyroid muscle is the muscle responsible for stretching the vocal folds and providing higher pitches. So, how do people present to us when they have a paralyzed or paretic vocal fold? That will depend on a number of factors. One is, first of all, is it a paralysis or is it a paresis or partial paralysis? Is only one vocal fold involved or are both vocal folds involved? Also, if one vocal fold is involved, where is it located? Is it paralyzed right in the midline so that the other one can make contact with it? Or is it way to the side so there's a big gap between the vocal folds? How close together are they? And then also, which nerves are involved? Is it just the recurrent laryngeal nerve, or are both the superior and recurrent laryngeal nerves involved? So there are a number of ways such patients can present. They may have voice changes. If there's a one-sided weakness, they'll have a breathy quality to their voice, most likely. The voice will be weak. They'll have trouble projecting. Obviously, if the superior laryngeal nerve is involved and the cricothyroid muscle is not working, they'll have decreased range to their voice. They may have swallowing difficulties. They may cough a lot when they drink water, or in a worst case scenario, they may actually aspirate and things may go down into their lungs. And they may have airway or breathing symptoms. They may suffer from what's called air hunger, and where they feel very winded because they're losing a lot of air when they speak. They may have stridor. They may have trouble getting air in. Stridor sounds like this, or some variation of that. And that's because they're actually having trouble getting air through the vocal folds into the lungs. And they may have a weak cough as well. So typically when someone presents with a unilateral or a one-sided vocal fold paralysis, their voice will be breathy because they'll have trouble closing their vocal folds, for example.
When the sunlight strikes the raindrops in the air, they act like a person.
It sounds as though he's whispering, but he's not. His left vocal fold, which is this one here, is not moving, so he can't close his vocal folds completely.
Happy birthday to you. Happy birthday to you. Happy birthday.
Do that happen.
When both vocal folds are paralyzed, typically they will end up close to each other. So the person's voice is not terribly weak, but they have trouble breathing.
Breathe.
Watch when he breathes in, his vocal folds don't open completely,
Breathe.
and you hear some noisy breathing, some stridor.
Okay.
Now, it's not always so simple. For instance, watch this lovely young lady who has bilateral, both vocal folds paralyzed, but her voice sounds like this.
When the sunlight strikes the raindrops in the air, they act like a prism and form a rainbow. The rainbows.
She allows me to show her face. She's been a big part of our practice and loves passing on the message of her experience. Her experience involves battling with thyroid cancer, which is what led to the paralyses of both of her recurrent laryngeal nerves. When you look at her larynx, you can see her vocal folds are not moving, but they're paralyzed far apart from each other. So the voice is very breathy.
Good.
She can't make a good sound. Now here's an interesting case. This patient here has both superior laryngeal nerves paralyzed from a thyroid surgery, actually. So her recurrent laryngeal nerves work, and she can open and close her vocal folds, but because the superior laryngeal nerves don't work, she can't stretch them. So when I ask her to slide up from a low note to a high note, she can't do it. Instead, hers sounds like this. See them opening and closing.
Good. Now go like this. Good. That's good. Thank you. Do that again.
She can't get a lot of range. She can't stretch them enough because, as mentioned, she has bilateral superior laryngeal nerve paralysis. Now, this is a busy slide, obviously, but basically it is showing what can cause paralysis of the vocal folds. And today, the most common cause of a paralyzed vocal fold is from having surgery on the neck. Before, that was equivalent with cancers. A tumor anywhere from the skull base to the upper lungs, anywhere where the recurrent laryngeal nerve is going, can push on that nerve and cause a paralyzed vocal fold. So sometimes we will identify a lung cancer in a patient who presents to us because they think they have laryngitis or they lost their voice. But in this day and age, surgery by far is the most common cause. We still always have to make sure that there is no malignancy if they present to us not having a history of having a surgery on the neck. Often also we find nothing, no cause, and we call that idiopathic and presume that the paralysis was caused by a virus. So how do we evaluate a patient who has a paralyzed vocal fold, or any patient who has dysphonia or hoarseness for that matter? Well, obviously we do a thorough examination and get a good history. Part of that examination involves looking at the vocal folds. And some of you may have had this in the past, but we often will look with a little scope that goes through the nose and looks around. Sometimes we'll use a scope that goes in the mouth. Here you can see someone having a flexible laryngoscopic examination. And here you can see someone having a rigid endoscopic examination through the mouth. So as part of the evaluation, sometimes we do need to obtain other tests. The most important is a CT scan of the neck and chest, assuming they have not had surgery prior to immediately prior to the onset of their paralysis. And again, we are doing this to rule out a malignancy or cancer. So let's move on to treatment. I hope this hasn't been overwhelming to you. If so, you can always go back, rewind, and watch again. So like any problem someone presents to a physician with, there are a number of considerations we make to decide what we would recommend for treatment. Of course, one, and perhaps the most important, is what does the patient want? Two is, what's their prognosis for the nerve regaining function? For instance, if they just had a thyroid surgery and they woke up with a paralyzed vocal fold, but the surgeon is absolutely certain that that nerve was well preserved, identified, and intact, there's a good likelihood, a high likelihood, that the nerve will regain function, although it can take up to a year. But if we feel it's going to regain function, we probably don't want to do any permanent surgical procedure on that vocal fold. Obviously, other things to consider would be the position of the vocal folds. Is this an airway or a voice issue? Are they aspirating? And what are they doing, kind of negative compensatory adjustments that might be inhibiting a better voice from coming through? So we work as a team at the Lakeshore Professional Voice Center, and voice therapy is a very important option for the majority of our patients. I'm going to let Juliana discuss that a bit later. So in general, surgery for a unilateral vocal fold paralysis is typically focused on improving the closure of the vocal folds, because again, the vocal folds have to close so air pressure can build up beneath them and cause them to vibrate. As I mentioned, bilateral vocal fold paralysis typically results in an airway problem, trouble getting air in because the airway becomes narrowed. So often the surgery for bilateral vocal fold paralysis is focused on opening the airway. And we're not going to discuss that much more today. So there are a number of procedures for one-sided paralysis. They're called medialization procedures. And basically they're focused on closing the gap between the vocal folds that's preventing a good sound from being produced. And these are, in general, the ones listed. What I left out here inadvertently, I see, were a number of reinnervation procedures that have been described. They don't make the vocal fold move again, but they do help restore bulk to the vocal fold, which can help with closure. So injection laryngoplasty and a type 1 thyroplasty are probably the two most common procedures performed, and I'll focus on those. For injection laryngoplasty, we are basically injecting a filler into the paralyzed vocal fold to bulk it up so that the vocal fold that moves can make better contact with it. It's temporary. Right now, there are no permanent injectables. So it's a temporary measure. It's very useful if we think the nerve's going to recover, but we don't want the patient to suffer talking like this for the 3 to 6 months it's going to take for the nerve to recover. Some patients prefer to have that rather than a type 1 thyroplasty, which we'll talk about momentarily. And some patients are too ill to go through a more invasive procedure. So the nice thing about injection laryngoplasty is it can very well be done with the patient awake with only a topical anesthetic. So we can avoid the need to go to the operating room. We can avoid the risks of a general anesthetic, the expense of going to the operating room as well. These procedures can be performed right in the office setting. And here you can see typically while someone is holding a scope from above so we can view the voice box on a monitor, we actually inject through the skin, through the neck, and the needle comes out into the voice box and we can inject into the vocal fold. And with a good injection, you can go from a voice like this.
When the sunlight strikes raindrops in the air, they act as a prism and form a...
To a voice like this.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow.
We're not making the nerve work again, unfortunately. If we could do that, we would probably win a Nobel Prize. We are just creating a geometric solution for the paralyzed vocal fold. We are closing the gap. So this video is going to show an actual injection. You'll see the needle come out here, what's called the pedo of the epiglottis, go into the vocal fold and plump up the vocal fold with the filler. It's in the vocal fold. You'll start seeing the filler and it will smooth out soon. And there you go. So the vocal fold is nicely plumped up. In fact, we over-inject it initially, so because some is going to go away very fast, and we want this to last as long as possible. And now the patient will be able to make better contact with the other vocal fold. This picture shows what we do with a type 1 thyroplasty. Here, this is a permanent solution where we are actually putting an implant in through a little window that we drill out in the thyroid cartilage, which in the men is the Adam's apple and houses the vocal folds. And we put an implant in and it pushes the vocal fold over. We might use what's called a silastic implant, or we might use what's a Gore-Tex strip. This is done with the patient under a light sedation so that we can actually hear his or her voice and fashion the implant in a way that it maximizes the vocal quality. Here are some live pictures. Here you can see the Gore-Tex strip being inserted. Here you can just see how we carve the implant. And in this picture here, you can see how we measure how deep the implant should go. And again, with a good tharoplasty,
The sunlight strikes raindrops.
you can go from a voice like this
It's a prism and a form, a rainbow. Rainbow is
to a voice like this.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. Rainbow
Again,
is division of white light into many
we're
beautiful
just creating a geometric solution to this neurologic problem. This diagram shows a procedure called an arytenoid adduction. This is a slightly more involved procedure when the vocal fold cannot be adequately medialized with an implant alone. For this procedure, a stitch is placed in the arytenoid cartilage. The arytenoid cartilage is part of the cricoarytenoid joint, which rotates the vocal fold, as I mentioned before. So basically, we are mimicking that rotation by passing a stitch through the cartilage and pulling it in such a way to rotate the vocal fold to the midline. Again, another geometric solution. So here is a patient. You can see this right vocal fold is bowed and very flaccid. Doesn't have stiffness to it. So her voice is quite breathy.
When the sunlight strikes the raindrop in the air, they're like a prism.
It's a little bit high pitch as well, and you can see here.
1 to 10.
1, 2, 3, 4.
She makes some contact, but that vocal fold is very bowed. I have to see if I can. Okay, and then after this procedure where we put an implant in and do the arytenoid adduction, her voice sounds like this.
When the sunlight strikes the raindrops in the air, they act like a prism.
It's stronger and more appropriately pitched. And here you can see the vocal fold will look straighter and have more tone to it. And closure will be better.
1, 2, 3.
Good, Barbara, go like this. Go.
4.
So those are geometric solutions, whether it's an injection, whether it's an implant or the arytenoid adduction, to move the vocal fold over to the paralyzed vocal fold over to the midline in a patient with a one-sided paralysis so that the voice can be improved by improved closure of the vocal folds. Now, I'm going to have Juliana take over to talk to you about voice therapy in the treatment of vocal fold paralysis.
Thank you, Adam. Well, as with any patient that comes to see us, it's because they have some kind of immobility to one or both of their vocal folds, and we're gonna obviously do voice therapy as a first treatment approach or as a post-surgical treatment after a medialization procedure. We want to know if that patient has at least some kind of what we call touch closure, because that is going to play an important role in the decision making of which exercises we're going to start with that patient. We're going to ask them to complete some self-assessment questionnaires. What areas of their life are most affected by the voice problem? That again will give us some valuable information. We're gonna do our own perceptual evaluation with our ears and grade how much roughness, how much breathiness, strain that voice has, and therefore build a treatment plan. Acoustics is everything we do with recordings that we take from the patient's voice, and we're gonna analyze those recordings after, and that will give us some objective data that we'll use to track progress and to see if we are on the right track, actually. And then there are some laryngeal palpation, there are some techniques where we push the larynx towards the paralytic side to help improve that closure initially, and that can be part of the stimulability process that we start at the beginning to gain some voicing, and then we can build from there with different exercises. The next one, please. And of course, as he said, it's a multidisciplinary approach. So in this slide, we have, there's a very busy slide with some pictures and lots of acronyms of things we use during acoustic analysis and aerodynamic analysis. For when we do the recordings, we have all sorts of measures that have a norm, and we compare the norm, what would be expected with normal anatomy, and how that patient is ranking regarding that. And then that's, again, what we're going to use to track the improvement and see if we're getting close to our goals. Aerodynamic measures, as you can see in that picture, I can over there, we're going to measure how much air the patient is using when they're phonating, when they're speaking. Then we have something that is called voice range profiles, that other picture with the piano down there, that shows the laryngeal capacity, what is the lowest note and the highest note that the patient can do in the softest and loudest volume. And that's very useful in those patients that have superior laryngeal nerve injury. We also do some, that EGG, the last one in the list, it shows us a signal that changes. It's a very low voltage that the patient cannot feel, and that will tell us how long in one of those vibratory cycles, for how long the vocal folds are actually touching or separated. And that also will give us information. Yes, the next one. And in voice therapy, we have two approaches. We use both of them. Initially, we start more with the indirect approach in the first session, which is basically education, counseling, if that patient is having that air hunger that we heard in the examples before. We're going to try to coach them to use shorter utterances so they don't feel like they're running out of air when they're talking. We're going to talk about voice amplification systems they might use to get out of the woods immediately. Obviously, we're going to talk about healthy vocal habits, vocal hygiene, like drinking plenty of water, of course, doing some adjustments that have to do with don't put back-to-back vocal engagements that may tire and fatigue your voice, and therefore you won't be able to deliver after the first one. We're going to talk about behavioral adjustments, smoking, and diet if needed. And of course, we're going to talk about the changes related to the swallowing and the breathing after a vocal fold paralysis or paresis. Regarding the direct therapy, go back one, please. We're going to work on those three subsystems that Dr. Rubin talked in the first slide, the first couple of slides. And we're looking to maximize the vocal efficiency in the presence of the current anatomical and physiological changes that we have. And in this next slide, we're going to see those three subsystems that we talked about. So we're going to work on balancing the airflow during phonation. So we're going to work on that breath support that is the power source of talking or singing. Then we're going to try to maximize the vocal fold closure pattern by exuberant exercises that might help increase that closure. And then, of course, we're going to work on the amplification system of our body, the vocal tract, that space that starts above the vocal folds and finishes in our nostrils and our mouth. That's our natural microphones. And these goals, based in physiology and voice science, is what we're going to guide our choice of techniques and exercises in therapy. The next one, please. So this is just a list of the names of some exercises that we might choose and some programs that we might choose for a patient with vocal fold paralysis. We're basically targeting the intrinsic strength of the muscles in the larynx, and of course with the breath support and the amplification system, trying to meet the goals according to that patient's needs. Next one, please. Breathy phonation, that's the voice that we heard in the examples before. That's the typical voice that we hear in a unilateral vocal fold paralysis, where the air is kind of leaking between the vocal folds. So the patient has this air, they feel winded when talking because they run out of air frequently. This is when we have reduced or incomplete closure. Sometimes after speaking like that for a certain number of days or weeks, the patient starts doing a lot of compensatory adjustments and adding a lot of tension, external and compensatory hyperfunction. So instead of being a breathy voice like that, it becomes a hyperfunctional voice with a lot of strain. So it's very important that through the course of voice therapy, we make sure what symptoms we're targeting and which are our goals at that present week, because it's a very dynamic process. And all those tools, assessment tools that I mentioned at the beginning are going to be very helpful to tell the voice therapist which way we should be going to help this patient at that moment. And this is a spectrogram. So as you can see, there are two pictures here. The one on top is the analysis of the spectrum, the harmonics that a voice has. And we use this a lot to assess the quality of a voice. As you can see here in the x-axis, we have time, and in the y-axis, we have these harmonics. And the harmonics are born here in the vocal folds, and we amplify them up here. So the first one, the first picture, as you can see, they're very faint horizontal lines and are kind of blurry. And in the second one, these horizontal lines are more defined. This is when the patient has achieved some closure, and we are able to, with some resonant voice therapy techniques or other different techniques, to help them amplify and make that message and that voice to carry it over a room and be more, have more intelligibility. The next one, please. Before any medialization procedure, it's very important to have this meeting to prepare the patient and to give them support, of course, and also to work with the patient so when they get to either the OR room or in-office procedure, they are in their best shape possible. So getting rid of any compensatory adjustments that we described before is very important, because once that gap is closed, they don't need to add all that tension. If they do, they're going to feel fatigue. They might hurt themselves, or they might be overdoing it, and that is not going to be a healthy vocal habit. So voice therapy in vocal fold paralysis has to be patient specific. We're going to address obviously the primary complaint of the patient, and we're going to be guided by physiology of voice science and motor learning purposes. This is a patient that didn't want any medialization procedures, so she just did voice therapy. If you play the pre-therapy recording.
White light into many beautiful colors. These take the shape of a long...
Not the typical breathy voice that we heard. She had, her paralyzed fold was paralyzed close to midline. So she did have some closure, and she was still doing a lot of compensation, trying to get her voice back to where it was before the injury. So after therapy...
When the sunshine strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is...
got rid of all those maladaptive adjustments she was doing, and she has a more efficient voice and more intelligibility.
So we're coming to the close of our talk here. I really appreciated Juliana's portion of this. We are a team here, and voice therapy we consider to be a very important part of treatment of all patients. Patients with spasmodic dysphonia as well often can help them maximize the effect of the Botox, again, relieve them of any maladaptive compensatory hyperfunction and so forth. So this last slide is meant for inspiration. This is the young lady who I showed before with the bilateral or both vocal folds paralyzed in a wide open position. So she had a very breathy, weak voice. We put on a World Voice Day concert every year in April. If you want to see this, you can go to our YouTube channel on Lakeshore Voice Center, search Lakeshore Voice Center. And she performs almost every year. This was after one of her vocal folds had regained function, so she became someone with a unilateral vocal fold paralysis, and after a lot of work with us at Lakeshore. And here is her performance, or part of her performance, at that concert.
Someone to watch over me. Someone to watch over me.
Thank you very much. Hope you enjoyed it. Okay.